afternoon, everybody. It's Heidi Simpson with Aging Services in Minnesota. Greetings on this cloudy, at least in where we're broadcasting from, day. I hope yours is summer-like in your part of the state as well. Thank you so much for joining us for today's webinar, Waiver and Alternative Care, Selecting a Quality Improvement Project to Retain a 1% Increase. Just a quick housekeeping announcement before we get started. To ask questions, on the right-hand side of your computer screen is a drop-down box that says questions. You can type in a question that you have and then send it to presenter. We will take questions at the tail end of the program when we have a little bit of time, and we really would like you to ask questions, so that would be great if you could participate that way. After today's webinar, we will be sending you an evaluation, and if you'd be so kind as just to take a couple of minutes of your time to complete that. It's just a few clicks, and it provides some very helpful information for us. So kicking off today's program is Mary Ewell. Oh, the speakers are there in the order in which they'll be speaking. This is great, so it'll help everybody follow along. And you should have received a PowerPoint presentation as part of the confirmation to participate in today's webinar, so please follow along with that. So Mary Ewell is presenting, Kathy Nichols is presenting, and Liz Sether is presenting, and all of their titles and background information that will be helpful for you are on the title slide. So I'm going to turn the program over to you, Mary. Thanks for joining us.
Hi, everybody. We'll move the slide forward in just a minute.
It's a little finicky.
Yeah.
If not, we're going to call for IT.
Oh, thank goodness for IT.
Yeah, we're going to. There we go. See, I told you.
I'm just going to do a real quick introduction. First, we'll talk a little bit about why it's important for home and community-based providers to focus on quality and have quality improvement programs. I'll briefly cover the Department of Human Services requirements that relate to the 1% of your 5% rate increase that rely on a quality improvement program. Kathy's going to get into the meat of the program by helping you think about potential sources of data that you can use to identify your quality improvement projects, and how to use the prioritization worksheet that Stratus developed to help you focus in on what you want to do for your quality improvement project. And finally, Liz will wrap up with information on how you can get more help, more assistance on developing your quality program. So the big question, why is it important for home and community-based services providers to work on quality improvement? It's not just because of that 1% rate increase, which won't even affect everyone. Certainly customers are looking for more evidence of high-quality services. You know, the consumer review sections on TripAdvisor and Yelp are exploding, and the more you can demonstrate through data, through documentation, to your customers that you do have good quality outcomes, that gives you a competitive advantage. And pay for performance is here to stay. Increasingly, home and community-based providers are going to demonstrate their importance to health plans and other groups if they can demonstrate through data that they have good outcomes in a cost-effective way. The health plan is going to be very interested in partnering with home and community-based service providers who can show that they can help reduce hospitalizations, reduce costs by those good supportive services in community settings. Finally, regulatory agencies are also focusing increasingly on quality, and those of you who have home care agencies know that the 2013 home care law now requires a quality improvement program for all home care agencies. And then we're going to get to the 5% rate increase that included a quality improvement project tied to the 1% rate increase. So just briefly, those requirements, and this is for providers who are serving waiver or alternative care clients. They have to keep that 1% of their 5% rate increase. They have to implement a quality improvement project by June 30th, 2015, next June 30th. Those projects have to address one of the 3 following goals that DHS outlined. And these are very broad, and there's a lot of latitude in how you go about meeting that goal and demonstrating that you've met it. The first is improving the quality of life of home and community-based clients in a meaningful way. The second is to improve the quality of services in a measurable way, back to the data. Finally, delivering good quality services more efficiently while using the savings to enhance your client's services. So again, 3 pretty broad goals, and there's a lot of different ways you can approach it to develop your project to meet one of those goals. Your quality improvement plan has to be submitted to the Department of Human Services by December 31st, 2014. Originally it was a little earlier, now it's been pushed back to the end of December. You have to use the DHS Quality Improvement Tool. We sent you the draft tool along with your handouts with the DHS Bulletin and the PowerPoint. So you can use that to start getting ready to do your quality tool. We understand there may be some minor changes to it when it's finally posted on the DHS website in October. So you can start working on that now. And now Kathy's going to get into the meat of the program.
Thank you, Mary. Just a brief introduction to Stratus Health. We're an independent, nonprofit Minnesota organization, and our mission is to lead collaboration and innovation in healthcare quality and safety, and to serve as a trusted expert in facilitating improvement for people and communities working at the intersection of research, policy, and practice. Stratus Health represents Minnesota in the Lake Superior Quality Improvement Network, which serves Michigan, Minnesota, and Wisconsin under the CMS QIO program. Stratus has been part of the CMS QIO program, working on quality improvement goals for CMS for over 40 years. Let's start with a brief overview of quality improvement. Here's a quote from William A. Foster. Quality is never an accident. It's always the result of high attention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice among many alternatives. And we're going to spend some time today talking about how you decide what it is you want to work on. But first, a little more background on quality improvement. There are 3 well-known and agreed-upon foundations of quality improvement. As various quality improvement or QI models continue to develop, other foundations are emerging as well. But these 3 principles show up in virtually every QI model. To improve quality, we need to focus on the customer, find out what's meaningful to them. We need to be process-oriented. That means understanding how to do something and working to improve the process, and to have improvement driven by data. Looking at the data you have, collecting new data, and discovering what information you get from that data to make sound decisions and changes to your processes. We also need to understand the 2 aspects of quality: quality assurance and quality improvement. Quality assurance is the process of meeting quality standards. Typically, quality assurance thresholds are set to comply with regulations or other standards. We want to know how the organization is performing. In healthcare, it's related to assuring care is at an acceptable standard and at a minimum maintained at that standard. Our monitoring for quality assurance is ongoing, somewhat anticipatory in knowing what you'll find, and retrospective in that you are always looking at your past performance. You're finding out where and why you're at risk or fail to meet the acceptable standards. Quality assurance activities do improve quality, but efforts frequently end once the standard is met. Quality or performance improvement, in comparison, is continuously improving processes. In healthcare, we are focused on better service delivery, better outcomes for the client, and greater client satisfaction. Often there is also a focus on reducing costs, eliminating duplication, and becoming more efficient. We identify an opportunity and act on it. We prevent a problem from occurring or change the system so it doesn't happen again. and we look at the system and processes to fix problems rather than focusing on individual behavior. So when we talk about quality assurance as a system and adding performance or quality improvement to it, we get QAPI. QAPI is found in most healthcare settings as a system for quality improvement. QAPI is found in hospitals, hospices, ambulatory care, and transplant centers. The Affordable Care Act required QAPI to be developed in nursing homes, and this change in regulation and focus is in process. And I'm sharing some of the common points that are used across all settings and can be used for quality improvement in your setting. In combining these two efforts, we're being proactive, always looking for ways to improve. We make decisions based on data rather than intuition or past personal or organizational experience. Improvement is everyone's responsibility and crosses all departments, and we monitor to ensure the changes we make are effective. So why is quality improvement important? Industries in the U.S., such as manufacturing and the airlines, have strongly focused on quality improvement since the 1970s. Understanding that improved quality leads to decreased costs because of less rework, fewer mistakes, and better use of time and materials. Improved quality ultimately leads to better products and services, and in the case of healthcare, better patient or client outcomes. Research also shows a correlation between staff satisfaction and customer satisfaction. And as Mary mentioned earlier, payers and regulators are more focused on quality improvement, and quality is being linked to reimbursement. And as the baby boomers age, consumers are becoming increasingly sophisticated in their knowledge of healthcare and what they expect for outcomes. These are all strong forces for organizations to focus on quality improvement. So where do we start? Again, quality as an organizational mindset and an individual mindset starts at the top. I can't emphasize the importance of that enough. If an organization's staff are not motivated and focused on quality, it's probably because the leaders are not, and quality improvement is not part of the overall strategic plan. Leadership makes decisions that influence quality by establishing a culture for improvement and allocating needed resources such as staff and time. Some attributes of strong quality leaders include things like a focus on the customer. All activities are linked to the customer and the mission of the organization. Leaders make it clear that quality is not an option. It's everybody's responsibility. They set rigorous standards. They create a truth-telling culture. Staff can report mistakes without fear of retribution. They create a safe place for conflict and respect of differing perspectives. They empower others to act, and they use data to make decisions. So, how do we pick what to work on? In all of our organizations, we have a lot of data and some data. Many organizations suffer from data overload and information underload. When you want to begin to use data, these are the questions that you need to focus on. What is it we want to learn? What type of data will we need? How will we collect the data? The period of time that the data will be collected, and is there available comparison data? Here are some sources of data you may already have or want to consider collecting. These include satisfaction survey data, satisfaction of clients, staff, referral agencies, families, and other stakeholders, falls data, complaints, staff turnover, hospitalizations, 911 calls, medication errors, emergency room visits, recreational offerings, antipsychotic drug use, accidents, incidents, or discharge summaries. Data collection tools typically include tracking tools and spreadsheets. Look at the data and use it along with team knowledge to improve your decision making. For example, maybe there's a complaint about a family being dissatisfied with the staff communication about their loved one. We can look at data to see how often does it occur. Is it really a problem, or is it a rare occurrence? How do we respond? As a quick fix for this situation, or as an opportunity to change our processes so these situations are improved for all families? Now we'll look at a tool to help us figure out what to work on. You should have access to a copy of this tool in your materials. This tool was developed for nursing homes, but can be used across any care setting to help focus team discussion on improvement topics. After reviewing the organization's data and identifying where we've not met internal or external standards, or where we can develop measurable improvement, we begin to list our opportunities. Pick from the data you have. You should have access, as I said, to this tool, but it also can be found at this link, and here's the website. You can also do a search for CMS QAPI, which will bring you to the website, and then under Tools Framework, you'll find many tools listed, and one of them is the Prioritization tool. The Prioritization worksheet for performance improvement projects is intended to help prioritize which projects you want to work on. As you're monitoring your data, it's likely that you'll continuously find multiple opportunities for improvement. Since you can't work on everything at the same time, it's helpful to have something that will guide you as you decide which projects you'll work on first. This tool helps you objectively decide which opportunities are most important and therefore could be the topic of a performance improvement project. The goal of this tool is to help you identify the problems that are high risk, high volume, or problem prone, as opposed to the opportunities based on intuition or just what someone on your team feels is a priority. You want projects to represent the overall organization and the client population. This tool is completed by the team that's deciding which projects to start first. If you have a leadership team or a quality committee, it will likely be used by them as the other team that reviews and monitors data and identifies opportunities for improvement. This team usually includes individuals from multiple disciplines, which is important because you want to choose projects that are important across your organization, and you want different perspectives. This worksheet is completed on a regular basis when you're looking at data. The frequency depends on how many projects are ongoing and how many improvement opportunities you're developing. You may want to revisit this tool at least every 3 months to determine which opportunities are coming up, which should be started next, and how you want to roll out the projects. First, we list all the potential opportunities that we have for improvement. Here you're seeing just one row across, but the sheet has multiple rows to complete. These opportunities come from the data feedback from families, staff, residents, providers, vendors, contractors, incidents, unsafe conditions, whatever data sources you have that we listed previously. We list those on the prioritization worksheet and try to be clear about what the opportunity is. Then we have a rating scale, and we rate each opportunity on a variety of items, such as prevalence. How frequently does this issue or concern arise in our organization? The group decides on a number from 1 to 5, with 1 being the lowest and 5 the highest. You also look at risk, the level to which this issue poses a risk to the well-being of our clients. Risk is often very highly rated for most projects, as we want projects that have better outcomes for our clients. Cost. The cost incurred by our organization each time this issue occurs. It may be an actual monetary amount, such as replacing lost or damaged items, or a cost such as, does this issue affect our referrals or our reputation in the community, is harder to get at. The relevance. The extent to which addressing this issue would affect clients' quality of life or quality of care. Again, we want to take into account whether doing a project in this area would improve our client outcomes. And responsiveness. The likelihood an initiative on this issue would address a need expressed by clients, family, and or staff. Another test would be if you put a sign up by your front door saying you're working on this project, what kind of a response would you get? How would clients, family members, or staff respond? Is it responsive to a need that they've identified? Feasibility, the ability of our organization to implement a performance improvement project on this issue, given our current resources. Ask the team, are there any reasons we know of that would prevent us from completing this project? Such as working on a project with admissions and realizing your admission coordinator is planning a medical leave in the next month. May not be a good time to start that project. Also, continuity, the level to which an initiative on this issue would support our organizational goals and priorities. Again, projects should relate to the overall mission and goals of the organization. Here's an example of the tool with 911 calls and satisfaction related to meals and a rating done by a team. Rating's subjective, and it's meant to be a guide and to stimulate discussion. Finally, add the scores across the row and tally in the final column. Potential improvement areas with a higher score indicate a higher priority. This gives us an idea of what's rising to the top as being most important for our clients and the organization. Some organizations do this at unit and our department meetings and at leadership meetings. Results from all are taken into account when determining priorities. Again, this is a discussion tool to help us prioritize and bring as many voices into this as possible. It's not done by one or two people. We want broad buy-in and support for the areas we choose to work on. Additional factors that we consider after looking at the topics include what existing standards or guidelines are available to provide direction for this initiative. What measures can be used to monitor the progress, and what type of changes primarily will be involved. System changes, environmental changes, staffing changes. Which staff will be most affected by the initiative? What training needs will this initiative present? Is there an identified champion for this initiative? Because we know that having a champion and having someone who can articulate and have enthusiasm for this project leads to greater success. The main tip for this worksheet is it should be completed by a team, preferably one that represents multiple disciplines within your organization. If only one person completes the tool, it doesn't have the same impact because you only have one person's opinion. Another tip is not to be overly concerned about the rating scale. The tool has a rating scale of 1 to 5, with 5 meaning most relevant and important, and 1 being less relevant. As team members share the ratings, it gives you a chance to discover and discuss why each person rated the opportunity as they did. For example, if one person rates an issue a 5 and another person rates it as a 1, that may be a great opportunity for the team to determine if this is a problem that's relevant to a small population. It may be a signal to the team that this represents a high-risk problem but doesn't impact a high volume of clients. Another tip is to be as specific as possible in how you describe your performance improvement opportunities in the left-hand column. If you describe opportunities too broadly, then it becomes difficult for the team to prioritize the projects. For example, if you describe a topic as client quality of life, it's hard to discern what that means. If you find you're having trouble prioritizing any topic, it's likely you've made the description too broad. If it's specific enough that it can be easily rated and prioritized, then it's also likely that if the topic is chosen as performance improvement project, it'll be more successful. That's because the scope's narrow enough that the team working on the project will understand it, and they'll know what they're being asked to do to complete the project. Many opportunities can come from a prioritization tool discussion. Look at the rankings. Think about the current and past quality efforts on any given topic. Discuss potential areas for improvement, and then select that area. So how do we know what the problem is? After choosing the topic, how do we know where to go next? This is when a team needs to begin analyzing the processes and system. You might use root cause analysis to figure out your root cause, or flow charting to break down the steps in a process and figure out what changes can be made. Or you may need to gather more information. Using these processes of digging deeper helps to engage staff in looking at why events occur, and it avoids the quick fix. You can't enter a project with a quick fix solution, having the solution before you really look at the issue. You fix what appears to be a symptom without looking at what really the cause is. And if you do, you'll find that the issue will continue to arise and you won't really have lasting improvement. So how do we make improvements? The improvement team should be an interdisciplinary team. Sometimes great ideas come from staff that are not involved in direct client care. For example, you may get very practical ideas from your business manager. He or she may not know much about client care, but may be able to think very logically. Here's the model for improvement. When you've picked a topic, then begin to ask the 3 basic questions. What are we trying to accomplish? How will we know that change is an improvement? How will we measure? And then what changes can we make to achieve our goal? This is where the team begins to brainstorm and really look at ways that they can make a difference. Look for ways to limit variation in the process, streamline the process, and simplify the process. Decide on a best practice. For example, what's worked at other facilities? Is there any literature out there, and what does it say? Plan best practice implementation or the action plan, putting it on paper and then putting it into practice. Monitor your activities to ensure the desired changes are occurring. Learn from others. Talk to other providers. Be more open to learning what others have already done on this topic. And don't wait for perfection. Just do it. Start somewhere and learn as you go. If you wait for all the answers or the perfect method, you'll never get started. We also encourage you to use the Plan, Do, Study, Act model, and it's as simple as it says. This model works well for small organizations because it does several things. It encourages learning by testing change on a small scale. It eliminates studying the problem to death. The PDSA model encourages a relatively short time frame between planning and actually setting the action or changes into place. It moves the team from analysis to action quickly, which allows those changes to take place quicker. It minimizes data collection and data overload. Minimizing data overload is especially important in today's high technology environment, and especially if you've got lots of data available. It also works well with small numbers. Maybe you've got a small population you want to work on, or maybe you're a small facility. It doesn't matter. The model works for any size. Improving your quality is a journey, not a destination. I love this quote by Maya Angelou. I did the best I could with what I knew, and when I knew better, I did it better. No one's expecting perfection with these improvements. Sometimes you go back to topics and you continue to do them. Here we've discussed a tool and a process to help you pick a project and covered some basic ideas on how to proceed. I'm now going to turn it over to Liz Sether to share additional information about opportunities for learning more about quality improvement.
I think before we jump right into that one, I think what we'll do is see if there's any questions on the that have been sent in.
Well, it looks like they might be busy writing them down, or they're not coming through. So hopefully it will give them just a minute or so to type some questions. And now it would be a great opportunity for you to take advantage of the expertise that that Kathy has to help you jumpstart your quality improvement project.
And while we're waiting for some questions, I'll wait until you give a signal over there, Heidi, that we got some on the tube here. Just to go back into, like, say, where the DHS bulletin that you had, on page 8-9 of that, it really explains what the quality improvement project is about and how you go about doing that. So on page 9, it goes into little bit more clarification on that aspect of it. And then where Mary said it is due the 31st of December, once you know those two things, there's also some great helps when you get to the provider quality improvement tool itself. Kathy has listed for you a whole bunch of areas in which you could be considering to do some things on there. However, this provider quality improvement tool that they've got, if you go to page 4 on that particular handout or that particular guideline on there, number 9 says, how will your project address the objectives selected above? So if you, those 3 objectives that you referred to, if you've gone sort of brain doesn't work, it's frozen in time or whatever it might be, Kathy gave you 3 ideas of things to probably work on, but number 9 goes into how will your project address the objectives, and it says, improves people's ability to perform everyday activities, increases independence, improves health. It just gives some great ticklers. It certainly doesn't say that these have to be what it is, but it certainly gives you, some idea for your team to sit down and say, we've got a couple of things in here. You may not have data, but you've got some gut feelings, or you've gotten some responses back from your clients that gives you some ideas. So I refer you to that because it kind of kickstart, like say, where do we get going to? And then you're going to need to identify what that project is before you get into that question number 13, which says, please briefly describe your project in 800 characteristics or less. And my question always was when I was writing a paper is, how many paragraphs is that? Or how many pages is that? Well, I do know that like 300 is about 4 paragraphs, and it's in a 12 font. Now, I never knew that, but small print or something like that. It's like less than a page. And so it says, briefly describe your project, 800 characters or less. So, you're not going to have to write a thesis about this. And then it goes on to say, how will you know your project is successful? In other words, how are you going to measure it? And that has to be in 300 characters. Question number 14 and 15, and this might be one of the areas in which they make a little bit of change when it comes out on it. But in 14, basically number 14 and 15 of this project provider quality improvement tool, 15 goes into identify the performance measures you will use to measure it. So those 2 things tie very closely together, in which you have to get down to the basics of, do you have baseline available data that says we have 42 falls, and you're going to get down to with injuries, and you're going to get down to if you're going to have any falls, it's going to be without injuries, so that your goals are measurable on that particular part on there. Then you're going to have to go in. Heidi, do we have any questions yet?
Not yet. No, I think there's
goodness
so
sakes. All 77 of you must, Kathy, you must have covered this so perfectly that we don't have any questions. But going on in that quality improvement tool itself on there, it asks you the questions about resources and if you want to share it. And the Department of Human Services is asking you if you would be able to, wishing to have information shared, whether or not you're going to be willing to share information and so on. And that is part of the collective benefit of having this and everybody participating in it, because I'm not into recreating tool or wheels. I don't know what the rest of the people are. I think those are some things that are on there. Mary, do you have anything to add?
Well, Liz, I was going to mention, Kathy talked about some of the ways you can, start to analyze the issue, the root cause analysis, and I believe we're going to be posting some sample tools on the DHS website. So there is a lot, as Liz says, there is a lot of information already out there. You don't need to recreate things. Use what others have done and build on that. I will say I know many of our home and community-based service providers have been doing collecting data. For some small providers, this may be pretty new, so you may not have a lot of data that you have been collecting, but increasingly it's going to be important for you to do that so you can show some measurable improvements.
It's all about the numbers.
Yeah. All right. Boy, I wish you were sitting in front of us here because I think we could tickle your brains as to what kinds of things that you've got going already. We certainly didn't want to whip on through this really quick. If we go back to the tool in the prioritization kind of thing, I know that that tool was used in skilled nursing facilities when they did the pilot test.
Mm-hmm.
Were there areas that providers had difficulty in using that tool, or what was the benefit that they found in using that tool?
It really was one of the tools. When QAPI demonstration project was done, we had about 40 tools. And so that's a little bit overwhelming. And sometimes like getting through this information and figuring out, okay, this is a lot of stuff and how do I get down to it? But this tool was one that I would say that every facility that used it loved it. They found that it really focused their conversations into what topics, and it really let them think about it a bit differently. You know, it was moving away from those gut level feelings of maybe we've got an issue here. Is it really an issue? And bringing all the thinkers in, the team members in to say, okay, let's really look at this and let's focus our conversation a little bit on what do we really think is going on. And so that they gave us the feedback that this tool, once they used it and used it several times, it became one that they kept pulling out. And sometimes they would take topics off the list, but oftentimes they'd go back in 3 months and say, oh, this one has changed because we've had another incident, we've had more data, and it was a way to track ideas as they went along too. So it became a favorite tool.
And I think, you know, Kathy talked about the team, and Liz certainly emphasized the importance of the team. For those smaller organizations, you may not have a quality improvement team. You may not have gone through that kind of organization. But as Kathy said, again, looking at the group of people in your organization, even though it may be small, who can represent different perspectives, different points of view, pull them together and kind of work through this with them.
Whenever you can, too, what we found with the nursing home groups is that whenever you can bring the resident voice in also, you want to do that. You want to go and ask them, you know, what if do you think this is an issue or not? Look at that client, talk to the families and say, you know, we're thinking about doing this project. Transparency is great. It's great for organizations, a great way to build trust. And so to be able to share that information. And yes, I know that many of the organizations have just a few people, but it's sure nice to have the tools and the structure to refer to. You may be the same people working on the same projects always, but at least if you develop your systems, it becomes easier. And also, get input from the people who have the most contact with your clients. Talk to your direct care staff. Get them involved. To really make it be a difference for your clients, you really have to get down to that level.
Mm-hmm. I was going to say, Kathy, and like say, having worked in some of the quality teams and those kinds of things, different organizations, different sizes, and you certainly hit on it. You may not have a quality coordinator. You may specifically design for that, but bringing in, asking the families, asking the clients, even asking, like, say, your admissions person to say, what are people saying, why I want to live here, why I chose another. Listen to what your community is saying. The other one is, like, say, if you happen to have had surveys and they have focused on a certain area, it might be an indication of something to do in it. But get to the grassroots, and that's why it's so important, like you said, get to the ones who are the direct caregivers, the residents or the clients themselves or the families, because sometimes they know things that, you know, are key and important to them, and it will come up on it. So you got a question over there, Heidi?
We do have a question. It's how often do we need to do a new one? I assume that the person asking the question is referring to this plan being submitted to the Department of Human Services. And at this point under the bulletin, it's this one time. Now, we don't know what's going to happen in the future, but we do know that DHS is very interested in pay for performance, and they do want to keep you know, quality improvement tied into reimbursement. So, but apart from that rate increase for those of you who are doing waiver and alternative care services, are these other reasons why you would continue to do quality improvement projects. And, you know, again, it's your competitive advantage, it's your ability to partner with health plans. Kathy probably can list a whole variety of reasons that can improve your efficiency and effectiveness in getting good outcomes. So at this point, as far as DHS is concerned, it's this one time that we know of. I'm sure there will be future bulletins.
Well, and like you said, Mary, we can't speak for DHS, but there's nothing in black and white that says you need to do 10 or 1 or 3. Or the thing is that they're going to get so excited about doing this quality improvement that, you know, once they get done with one project, they may go right on into the next one. And then depending upon your size, you may have a couple of them going.
Right.
I would warn you, if you haven't done a whole lot of quality improvement before, don't solve the world. Really take a look at and say, what is an area that we really can, and you know, the quality improvement oftentimes done in, like say, in the settings that we're talking about, like say the waiver, assisted living, and all those kinds of things in home care. A lot of times, you know, like say the quality improvement was done in an informal manner. It was just problem solving. This is just putting a format to it.
Yeah, that's right. And I think there are times that problems come up that you're not going to turn everything into a formal project. That's why the prioritization tool helps with that too. You know, is this happening often enough that we really need a project on it, or do we really just need to solve a problem? And it's a way to just broaden out the effects of that. So as Liz said, you just have to try, you know, that's why we left the last slide up here. You do the best with what you knew at the time, and then when you know better, you can do it better. You can add more. You can do more projects. But as Mary said, I don't believe that the focus on quality improvement is going to go away. We all are driven by our choices and what's out there, and certainly for these settings, we have to be able to demonstrate some aspect of quality.
Liz, we have a question about the quality improvement tool that DHS issued. Question 6 refers to the provider being contracted with a health plan. And the question says, now that we don't have direct contacts with counties, let's see, we don't have those kind of contracts. Is that the end of the question?
With the health?
Yeah, with the health plans.
I think that question is only for those that they have a contract with them. Because if you look at, this covers a broad provider group of people, and they're in the providers that are listed that are under this 1%. Some may be under contracts and others may not. And so, you know, I also looked at some of the questions that they asked in here and kind of go, well, this might pertain to this setting and this may not pertain to another setting.
And I believe DHS is setting up their quality website that I would expect that there will be an email address that you can send questions to DHS staff about if you have questions on filling out the form. Again, the form may change slightly before it's posted in its final version sometime in October.
In fact, if you bump the slides up here ahead a little bit, well, Kathy's going to take all kinds of questions, anytime of the day, night, whatever.
Whenever. Give me a call.
And I think this is where going to that DHS website is listed, where they would be able to find that information on there. So, any more questions on that?
Oh, yeah. And we have a very small drop-down box, so which is why we're not capturing the, it's taking a little bit to capture the questions. But this one says, could a project be related to staff turnover and then link it to improving the quality of life for the client, because core staff would give them continuity of care?
Definitely.
Absolutely.
Great one to pick.
Yeah.
If only we could solve the problem really quick.
Yeah.
But there have been people who have taken on staff turnover and have implemented some great ideas, and that's important, especially in that area where you get the staff who are involved and getting their input as to what would make a difference so you don't have the turnover. There's some turnover, of course, that can't be changed.
Right.
The husband's got a job or the
Right.
wife's got a job and they're
We've
leaving
got
town.
students or whatever it is. But I think staff turnover is an example of one of those where you really want to focus on what's the problem, what's the issue. We've got staff turnover, but what does it really relate to? You know, when is our staff turnover occurring? Is it within the first 3 months of hire? Is it within the first 6 months? Is it after a year? What kind of feedback are we getting from the people that leave our organization? Is it that we need to do more work on recruitment, or do we need to do more work on our orientation? You have to really focus on what's the issue. And that's where these topics really, it helps to get at it, but you have to drill down to really figure out what's going on.
We have another question about the DHS bulletin number. The number that talks about the 5% rate increase and the quality improvement plan that needs to be submitted is bulletin number 14-69-03. And those bulletins are available on the Department of Human Services website, or you can always contact us here on the Aging Services staff if you have trouble locating them.
Okay, and then here's another long question, so I will do my best to get through it. Okay. What about the upgrade and implementation of software that captures resident data? And they gave examples. We currently use Residex and Eldermark, but not everywhere uses, you know, the technology. We think this will provide better productivity and recording for the staff, but also provide more immediate availability of information to our care providers while caring for our residents and clients. So it kind of sounds like, you know, would technology count?
Oh, absolutely. Any place that you can collect, usually with that kind of technology, you also have the opportunity to pull some reports from it. Mm-hmm. There's usually some way to aggregate the information that's there. So those are very helpful tools, but not everybody has those tools, so you have to have an understanding of how to collect data as well as using the technology.
Mm-hmm. And it sounded like when you were talking about addressing the earlier question with pulling staff turnover data, it sounds like an HR department is going to have some data that would be helpful for that, and maybe some other things related to staffing.
Right, right.
But again, some of you may be very small and may not have an HR department,
right.
But you could start an Excel worksheet and start, you know, gathering that data about your staff turnover or your falls, hospitalizations, any of those kinds of things you want to track.
And when you talk about the Excel and all those kinds of things, Mary, sometimes where that is accessible is in the business office. And so, I mean, when we're talking about getting the team involved, it may not be just your direct people who are giving the services, but you may incorporate the whole operation, really, to say, who can get this done and who can collect the information. And if you don't have an Excel and you don't have any of those, there's always that little checklist kind of thing in which most people have moved way beyond that. But it is a method in which can be done.
You might also want to be looking at the, you know, whenever you have a project that you're trying to manage, you're looking for different skill sets, like someone who is really good at project management, somebody who's really good at research, someone who takes maybe a devil's advocate position when you're looking at your project to ask those really tough questions.
And who can run good meetings,
who can run
who
right.
can coordinate,
and
good consensus and so on there. If there isn't any more questions right now, maybe I'll just say just a little bit about the different locations that we will be at. A couple of sites have been located. We're going to be in the areas. On October 13th, we're going to be in the Detroit Lakes area. And on the 16th of October, we're going to be in the Grand Rapids area. The 21st, we're going to be down in the Southwest area. And any of you who are down in the Southwest, you guys must be doing everything down there because everything is all tied up down there. So we have not located a specific location, but it will be in the Southwest corner so that we're trying to prevent people from having to drive so far. And then on the 22nd, we'll be in the Twin Cities metro area for that. During those sessions, what we're going to try to do is how do you establish a quality system that will guide the performance practice leading to satisfaction, improving your quality of care, and the likes of that. So we'll be going over some key elements for the quality improvement programs, of which the quality improvement project is only a part of, because there has to be something behind how do you get this thing going and so on. There will be the organizational structure, how do you get that support in there, and who is that going to be. And then we're going to review some sources of data that is available. So you don't, like Kathy said, you don't have to create new or more. And then how to collect, and then also how to look at how to trend it. You know, there's bar charts and run graphs and all of those kinds of things. And so we'll be going through some of those tools so that you'll be able to see what some of those things can be done in. We'll also experiment a bit with quality improvement tools so that you'll have a chance to test those out. So in other words, there will be some small group work done. With that, we'll keep it a very informal session so that you can go home with information to how to plug that into yours, and so you can develop your quality improvement. And then by the time you leave, you should be able to have in hand a rough draft of what your system will look like and how to put that toolkit together. Besides, and you know, like say when you take a break over the lunch period or during the break time, those kinds of things, you may hear from one of your colleagues that kind of go, hey, we're thinking about doing this. You kind of go, never thought of that, but that would be a great idea. So there'll be some time for networking, which will be helpful also. Other than that, Heidi, I don't have anything more unless there's some questions.
Not anymore. Not anymore. I think they're going to hold out until for the workshops.
I think we could say that the actual time of, you know, there's registration. They'll start like say 8 or 8:30, but the actual session will begin at 9 o'clock and go till 3 o'clock for that particular time. So.
Yes, and there will be CEUs attached to that. So that's always a good thing. So thank you, everybody, for participating. For the folks who asked questions, really appreciate that very much. And again, if you could take just a couple of minutes to complete the online evaluation, we'd really appreciate it. That will help inform the workshops to come and then the work on the quality improvement project. So thanks so much for participating. Have a good rest of the week, and cross your fingers we get to extend this extended summer a little bit longer. Thanks so much. Bye-bye.